we're like Skinner's rats. We know when to hush because the session is starting. Can everyone hear me all right? Yes. Okay. So I'm going to introduce myself. I am Stephanie Sog. I'm a clinical psychologist in Boston, Massachusetts, but I don't have that funny accent. I work at the Massachusetts General Hospital Waite Center, and I'm on the faculty of Harvard Medical School. And I'm also the immediate past integrated health president for ASMBS, and I'm delighted to be here today at our session addressing mental health challenges. What can healthcare professionals do better? And the purpose of this session today is to provide insight into the ongoing mental health challenges that patients face after metabolic and bariatric surgery, and to discuss some interventions that we might have at our disposal. So just out of curiosity, how many people in the room are not behavioral health or mental health professionals and they're here to learn more about that? Raise your hand. Oh my God, that's fantastic. Usually we're just talking to ourselves. So that's wonderful. And we have two very, very qualified moderators for today. We have Kylie Murphy, who is a clinical and health psychologist with more than 12 years experience supporting bariatric and metabolic surgery patients before and after surgery, and people struggling with disordered eating, eating disorders, body image dissatisfaction, and attachment trauma. Would you like me to continue with your many qualifications? All right, I think apparently Kylie says everybody in the room knows her. And then we have Dr. Simon Morris, who's a clinical psychologist who works in medical psychology and works closely with medical specialists, including metabolic and bariatric surgeons and endocrinologists and neurologists. And he is in private practice and also works in partnership with the St. John of God Hospital in Geelong. Is that how you? Geelong, in Australia. So we're going to dive right in because we want as much time for discussion at the end as possible. And I'm going to introduce our first speaker. And pardon me, it's obvious I'm just reading this off of my phone, but Dr. Vash Singh is a psychiatrist. She's the medical director of, ISIS Center, Australia's first integrated eating disorder day hospital. She has worked in the field of eating disorders for the past decade. She and her team at ISIS Center have developed an evidence-based integrated group therapy program for patients who are considering metabolic and bariatric surgery or who have undergone the surgery, providing psychosocial interventions including CBT, DBT, and if you don't know what those letters are, I think you'll probably learn a bit about them today, exercise physiology and dietetic support designed to optimize both physical and psychological outcomes post-surgery. So welcome.
Thank you so much, Stephanie. I was very excited to be invited to this meeting. I'm not sure how many psychiatrists have been asked to speak before. But then I was really disappointed when I was asked to speak about medications. And I did consider not talking about medications because actually it's probably the most boring part of the talk. But then I do want to be invited again, so I thought I'll do it.
It's not boring for us.
So page down, where would that be? Is it that one?
Yeah.
Okay, so looking at psychiatric morbidity in bariatric patients, I think these two studies, the Kalachian and the Mulhouse studies, looked at lifetime prevalence of psychiatric disorders in bariatric patients. And the reason why these studies are thought to accurately represent the rates is because they used structured interviews, and for another, they actually informed patients that unless these problems posed a direct safety risk to surgery, they wouldn't actually be telling their surgeons, because of course people are always worried about revealing mental health difficulties and specifically eating disorders if they think that they're not going to be able to access surgery as a result of that. So you can see from those rates that that's pretty high. And then the longitudinal, the lab study, I think it's longitudinal outcomes of bariatric surgery. So there were three kind of studies, and the third one was looking at psychosocial outcomes. And they estimated, so at the beginning, before people had bariatric surgery, major depressive disorder was the commonest disorder that we see at 39%, alcohol use disorder 33%, and eating disorder 16%. But we do know that eating disorders is actually, it's underdiagnosed in the population in general, and probably even more so in bariatric patients for the reasons I've spoken about earlier. here. We know that the most common medication class used in the past 90 days prior to surgery was antidepressant medication, with about 40% of people being on this type of medication. But that 82% of people on medication actually continue to take their psychiatric medications after bariatric surgery. And in terms of the pharmacokinetic effects of bariatric surgery on medication, so with restrictive procedures, we can get the passage of pills being impeded, we can get irregularities in medication absorption and also in the effect of these medications. So, and also restrictive procedures will restrict the amount, obviously, that's what it's meant to do. It will restrict the amount of available caloric intake that a patient can have in one setting. Now, I'm not sure how many people are aware of this, but there are psychiatric medications that actually require a certain kind of caloric load in a meal for the medication. They have to be taken with the meal, and absorption is best if you have a certain caloric intake with that meal. So for instance, two antipsychotics in particular, lorazepam, which is on the PBS in Australia for schizophrenia, patients would need to have it with a meal that's at least 350 kilocalories, and when we've had a restrictive procedure and we can only have 250 kilocalories, absorption is definitely going to be reduced. We don't have ziprasidone here, but it is a medication used in the US and in other parts of the world, and that requires a 500 kilocalorie meal. So you can imagine absorption of ziprasidone would be impaired by about 90%. And you might say, well, yeah, like change those medications. They're really great medications, actually, for schizophrenia and psychotic disorders, because traditionally we've had medications that have caused obesity, that have actually had, other metabolic side effects, and then they've not been nice drugs to take. So these are actually, patients that go onto them, they're A, effective, and B, they have much less of a burden of side effects. So if we're going to change those medications, it could have quite a significant impact on the patient. And then we have, of course, the malabsorptive procedures, which can decrease absorption of medication. So, for instance, cytochrome 3A4, which is responsible for metabolism of a lot of psychotropic medications, that is released in the small bowel, in the proximal part of the small bowel. So if we have this portion removed or bypassed, we're going to have less 3A4 metabolism prior to absorption of the medications. And the medications that would be affected here would be citalopram, mirtazapine, quetiapine, carbamazepine, or again, with the exception of carbamazepine, the first three are actually quite commonly used for depression, for anxiety. Quetiapine is used across a variety of disorders. And then, of course, everyone's advised to stop smoking, which obviously is a good thing, not just for the surgery, but it's a good thing for their life and, other adverse health outcomes. However, cytochrome A1A2, which is induced by smoking, what tends to happen there is we have lower levels of cytochrome 1A2 when people stop smoking, and then we have increased drug levels of things like clozapine and olanzapine, which are actually metabolized by the cytochrome 1A2 enzyme. So we might then have increased side effects from these medications, sedation, again, weight gain, hypersalivation. So what will we do with patients who are on psychotropic medications? Well, this is why I think it's really important that we have psychiatrists from a medication perspective involved, not always, but certainly all primary health physicians, because we do need to get a baseline mental state examination and also, good measures of where their illness or disorder is at the current time. So standardized rating scales obviously are best to be used because they give us a more objective measure, and if possible to have plasma levels of medications. Not all medications we can get plasma levels, but there are some that we can. And then in consultation with the surgeon, have an idea of what type of surgery the patient is going to undergo, and then think about the medications that they're on and whether it's going to actually affect absorption, whether they're likely to have increased levels of those medications or decreased levels. and also educate the patient on any potential for malabsorption, and how do they distinguish between withdrawal symptoms of medication, so if they have lower levels, versus that they're actually having a recurrence of depression, for instance, of major depression. And also that they may actually have increased side effects from medications like clozapine and olanzapine. But the only currently agreed proactive psychopharmacology measure is actually to change a modified release or a slow release medication to immediate release. And there are a lot of psychiatric medications that are slow release. For instance, one of the more commonly used antidepressants, IFSO XR, so that's venlafaxine long-acting, that would need to be changed to an immediate acting preparation. But otherwise, we really would try not to make major changes to a patient's medication regimen if they are stable prior to surgery. So after surgery, we obviously want to keep the metabolic burden of the medication regimen as low as possible. But I've actually had patients whose medications have been stopped, psychotropic medications, which they've been stable on for a long time without consultation with me. And that tends to get quite difficult because then I'm managing the downstream effects of their recurrence of psychosis or depression. And actually, I'm not sure how aware people are that it's probably an over kind of the risk of weight gain from psychotropic medications, not all, but most of them. Obviously, olanzapine, clozapine, we're talking about very significant risks of weight gain, but most medications, psychotropic medications, don't confer a huge burden in regards to weight gain. So in studies that looked at percentage weight loss in people taking psychotropics compared to those not taking psychotropics prior to surgery, there was no difference. And there was also no difference in percentage weight loss in those taking psychotropics at 1 year post-surgery compared to those not taking psychotropics. So we should monitor mental state closely post-surgery, but also monitor for the onset of other conditions, which we know happens not infrequently in post-bariatric patients, and that would be alcohol use disorder, other substance use disorder, gambling addiction, and of course the onset of body image disturbance, specifically linked to loose skin, and the onset of eating disorders or even disordered eating. And adjustment issues in regard to eating, lifestyle, and coping mechanisms. And I think we're all clear that successful bariatric outcomes, is not just dependent on the surgical procedure, but also on, it also requires significant and lifelong changes in how a patient eats, their relationship with food, their relationship with physical activity, their ability to manage stress, and their ability to utilize other coping mechanisms for distress if food has been a very important part of that. So my final slide is to say that that there is a role for psychiatry and psychology in bariatric surgery. I hope there isn't any dissent regarding that in this room anyway. But pre-surgical assessment to identify at-risk patients who may benefit from interventions, psychological interventions or psychiatric interventions after surgery, and sometimes even before surgery. As I've said to my bariatric colleagues, if someone is binging and purging 10 times a day, you're unlikely to get a good outcome post-surgery unless we address that pre-surgery. So we're not gatekeepers, and we don't want to be seen as I think people have sometimes thought, I don't want to say these things, I don't want to include a psychiatrist because they're going to tell me don't do the surgery, and that's certainly not the perspective that I come from or that we should be coming from. It's about optimizing the mental state as well as the physical outcomes for a patient who has decided to go down this path, and which and hopefully a patient that's deemed to be appropriate for surgery. Motivational interviewing is really important to improve their motivation for adopting non-surgical measures like managing stress in different ways, changing their relationship, having a more adaptive eating pattern, and utilizing exercise in their recovery post-surgery. but also moderating the level of expectation from surgery, which I find in my experience, people have very unrealistic expectations, and also potential roadblocks they may face. Because remember, a lot of these people have believed for a lot of their life that all they need to do is lose weight and everything will be better. And that's not the case, and certainly that isn't the case from the studies that look at downstream outcomes of depression and even suicide, which is 5 times higher in this population. So post-surgery, continuing to monitor their mental state and medication review. And in terms of interventions, so at IFSO Center, we have a group therapy for post-bariatric patients, and that is utilizing cognitive behavioral therapy as well as DBT. So DBT is dialectical behavioral therapy, and it's quite skills-based, essentially learning how to manage distress better, to regulate emotions better, to manage interpersonal relationships, because that also is affected by surgery and the change in the way someone looks. And then also group therapy prior to surgery may be a beneficial intervention that we're starting. No, that's all right.
Thank you so much. Wonderful talk so far. So next, I have the pleasure of introducing Gemma Sharp, who's a clinical psychologist and an associate professor who leads the Body Image and Eating Disorders Research Program at Monash University. And she's also the director of the International Consortium for Research in Eating Disorders. And she's held consecutive Australian National Health and Medical Research Council Research Fellowships since 2018, and is a current Emerging Leadership Level 2 Fellow, which sounds very impressive, although I don't know what that is. And she is a senior clinical psychologist working in the public and private sectors and a nationally credentialed eating disorder clinician. So welcome, Dr. Sharp.
Thank you so much for that introduction. I should have made it shorter. I do apologise, and we just say EL2 for short. It's such an honour to be here today to speak to you all. Where's the clicker thing? That's the clicker. Oh, thank you. Thank you. Sorry, everyone. Such a huge room of people, and I look forward to sharing some insights into body image dissatisfaction. I have nothing to declare. So I think sometimes people think that body image is potentially a simple concept, but it's not. There's actually 4 aspects of body image, and I ask you all to keep these in mind while I'm talking. So first up, there's perceptual body image, how we see our bodies. There's also affective body image, so how we feel about our bodies, and obviously that can be a positive or negative or neutral. There's also how we think about our bodies, so cognitive body image, and then there's behavioural body image, and some people may consider seeking bariatric surgery to be a manifestation of behavioural body image. So I thought I'd better check the literature while I'm preparing this presentation, and I was like, oh God, there's going to be loads, isn't there? And then I did my searches and there wasn't, and I was like, oh, phew. But then I actually started reading everything and I was like, oh, this is a bit of a mess. So come on me with this journey of this interesting literature, shall we? Okay, so I include this graphic mostly because of the hilariously inappropriate bikini picture. It just really tickled my fancy. But more broadly, this is quite a recent study. It has a lot of patients, 400, and it follows them up over a long time, 3 years. We don't have much research like this, so this is why I wanted to share this graphic. And we can see here in this results panel, so the body image section is the bottom. So clearly, body image improves over the first 12 months after surgery, but then it dips down a bit. And who knows what happens beyond the 3 years? We don't know. So clearly, there is a significant increase in body image overall, but it's not maintained. It doesn't keep that high level, that kind of halo effect you see at the 12-month mark. And I show this slide because the way we measure body image seems to be radically different in these studies as well. If we use like a generic measure of body image, we're potentially not picking up on some of those key factors of body dissatisfaction that are specific to bariatric surgery, particularly loose skin. And we can see here on this slide, so these were patients seeking body contouring after bariatric surgery. And we can see here that the amount of endorsement, distress, and impairment they're talking about because of loose skin, I didn't include the whole table, but it also had talking about bariatric surgery scars, was really quite high. So this research, I suppose it depends on which measure of body image we're looking at, what questions we're asking. There's clearly something going on here. Some people's body image will improve after bariatric surgery. Some people's won't, some will stay exactly the same. We just don't know. There's also definitely links between body image and self-identity. And I refer specifically to dialogical self-theory by Hermans. And very briefly, you're welcome to go check it out yourself. But basically, our sense of self is not static. It evolves over time. And clearly, someone who's undergone MBS, that is a huge shift in identity. And this particular study that I reference here talked about people who maintained an I am obese core belief or mindset after surgery versus those who were able to adopt an I am ex-obese as a new mindset. And I really liked this quote, which is why I included it. So a post-operative patient, it's true that you lose weight in the body, but you cannot lose weight in the same way in your head, or any way, certainly not at the same speed. And I wish they'd lost that extra O in the loose weight, but nonetheless, I think it's still a great quote and really, I think, speaks to that huge shift in mindset that some people will maintain that I am obese even with a radically different body. So there's clearly a difference between body and mind. So what can we do about it? Well, I wish I had some easy answers for you all. The more I read and the more I thought about my clinical practice, I was like, oh gosh, I don't know. But I'll do my best. So there's no one way. But if I bring you back to those 4 facets of body image, I think it's about talking with the patient and making up a plan together that is best related to their particular concerns. Is it to do with loose skin? Is it the I am obese mindset still maintaining? There are different strategies we can use to address each of these different concerns. So we've talked a little bit about CBT, and cognitive restructuring is one of those classic CBT concepts. And these quotes are from a study where the patients were kind of already doing their own cognitive restructuring without any health professional input. And I really like this quote here. It says, this BMI cutoff, according to that, I would need to weigh 55 kilos to be normal weight, and not a chance. I would not be healthy if I weighed 55. And the second quote there, but I still look good in my own flesh, and I'm a chubby person and it suits me. That's how I'm made and it suits me better. So they've come to this point of acceptance with this new body. And so they've done their own, I suppose, mindset shift. I absolutely love this exercise. It's quite famous in eating disorder treatment, but it's basically helping people shift the way they evaluate themselves, which can tap into that self-identity. So the pie chart on the left is someone who is over-evaluating their shape and weight in how they perceive themselves. That's why they've got such a big blue section. But the pie chart on the right, it's more balanced. We can see things like work, family, friends, dance, music. They're also important to that person's self-evaluation. And so this is something we can work with patients on together. How do we get you a bit more of a balanced pie chart, a more balanced self-evaluation, which is less about your body shape and size? And I always show my students this one because this is my pie chart and it is a disgrace. I clearly need help. So yes, I can work on my own balance. And this is virtual reality stuff. And I know you're going, Gemma, I don't have virtual reality gear in my clinic, and I appreciate that. But I think this is closer than ever before, and I certainly do research in this space as well. What we can do is pre-surgery, we can show images like on the left, showing people how they might look after surgery, and on the right, how they would interact in their normal environment. So that's obviously a bedroom setting there. This is really tapping, 2 minutes, yep. This is really tapping into perceptual body image and helping people prepare for that shift. This last one is about a program called Expand Your Horizon, and it's focusing on looking at or appreciating our body's function rather than the aesthetics. And there has been one study showing that this Expand Your Horizon program may have promise in bariatric surgery patients, but more research needed. I'm going to use my final time for a plug. This is a big room of people and I'm going to make the most of it. As Stephanie said, I'm lucky enough to be the leader of the International Consortium for Research in Eating Disorders. It's a first of its kind initiative, bringing everyone together in the eating disorder space. That includes people working in obesity and higher weight. We want to hear from you. We'd love for you to be part of our consortium. If you scan the QR code, you can join. It's free membership. What have you got to lose? These are my contact details. If you would like to reach out more to me, feel free to scan the QR code. Thank you all so much for listening to my ravings about body image.
My reality TV research grant pie chart would be the mirror image of that. So next, I am pleased to welcome Dr. Rachel Gold, who I just want to give a shout out to Dr. Gold, agreed with very short notice to give a talk to take some of the huge burden off of Kylie, who's doing many, many talks this week. Dr. Gold is a registered psychologist working in private practice in the treating of eating disorders with a particular focus on people with binge eating disorder and higher weight, which has led to her working quite a bit with people who are having or who have had metabolic and bariatric surgery. She's also a member of the Australia Psychological Society, ANSMOS, and she is a credentialed eating disorder psychologist through the Australia and New Zealand Academy for Eating Disorders.
Thank you for having me. Yeah, sounds good. I've timed mine many times, so I'll be okay, I think.
Psychologist.
Yeah. I'm so excited to be here. And in terms of this presentation topic, it's very broad, and I think the first draft I sent Stephanie was probably an hour's long, so she very kindly encouraged me to trim it down. So there's a lot to say on this topic, and I guess in terms of what I wanted to sort of share with you today is a bit of an insight into what therapy can look like for this population. And it's based on my 11 years of being a psychologist working in the eating disorder space. And I've been working about 4 years with bariatric patients and sort of learning as I go and following up with my knowledgeable colleagues. I'm really excited to share with you a bit of a, as Gemma sort of phrased her talk, a bit of a journey through what therapy can look like. And I've broken it down into 3 stages. And I'm very keen to hear people's thoughts and feedback because this is such an emerging area and I'm certainly not going to pretend that I'm the expert. There's no conflict of interest. But the first thing that I think is really important is if you do have the opportunity to meet with someone prior to surgery, it's such an opportunity to help them out. As Cal said earlier in the IH conference section, it's an opportunity to strike when the iron is hot, when the motivation is present. And I think one of the big things that you can do as a health professional in that initial stages is to talk about realistic expectations, help people get informed about what they're about to undertake, get them to think about who is in their support team. I'm surprised by how many people don't even have a dietitian when they come and see me, and I get them linked in. And to really help them think about, their mental health, their life stresses, and their readiness to change. Because I'm not going to say to someone whether they should do it now, but I think that it's really important to empower people to make an informed decision because it's such a huge undertaking. And if they're ready to go ahead, then we can help them with a lot of skills training, like problem-solving skills and setting SMART goals. So the other part that I like to do before surgery is, if I can, is help people understand their weight gain story and to help them understand how disordered eating or their eating disorder might have contributed to that. I really like to be able to label someone's eating disorder experience with a diagnosis, even if it doesn't meet full threshold, because I think it's just such an opportunity to de-shame the person, to help them have hope that treatment can really help make some change. And even if they don't, make some progress before the surgery, it's such a good opportunity to get some momentum and make the whole process a much more positive experience. There is evidence for self-monitoring being helpful in terms of protecting against weight regain, and self-monitoring is something that all good eating disorder psychologists do, and I like to use the Recovery Record app, and it means that I see real-time data from my clients, and I usually can link them up with their dietitian as well, who's an important part of the team. In terms of motivation, it's a very elusive concept, and it's something that psychologists are well placed to help with. And we really need to normalise for people that motivation changes and readiness to change fluctuates. So when they're feeling motivated, we can come in and really help them prepare to maintain motivation for the weeks, months and years, which is this journey. And we can help them think about values-based living, primary goals, which talks about the reasons outside of weight loss for why someone would want to undergo this surgery, and really help them really be clear on their reasons for change. And psychology, as much as it's evidence-based and a science, it can be an art, and there's so many really nice creative interventions that we can offer our clients to build motivation, and this is something that you do throughout therapy. The first year after surgery is a little bit different to 12 months after surgery, and I think a lot of people probably know that. It's a huge change, and it can go really well for some clients, but others it can be quite hard. There can be a lot of adjustment. The shock of having their safety blanket of food taken away can be very distressing. So that's where a psychologist is really well placed to help them through this time. And there can be all sorts of other stuff that comes up. And you really ideally have good therapeutic relationships so that you can help your clients with those difficulties during that time. Like, at the moment I'm dealing with someone who's going through medically necessary termination, and it's a very distressing time, but I'm glad that she's seeing me. In terms of emotions, I think people would be quite aware that food can be the thing that helps people manage their emotional experiences and needs. The classic is a stressed out mum who turns to food at the end of the day to take care of herself. And so teaching them about how to manage their feelings and meet their needs can be such a powerful intervention, and psychologists have so many ways to do that. And there's lots of different therapeutic approaches, including CBT. The other thing that we do well is help people identify our unhelpful thought processes that Gemma alluded to earlier, and helping people really identify the thoughts that drive the undesirable behaviour, and really helping people build up a more self-compassionate, flexible and realistic way of thinking that's a bit more big picture and long term, as opposed to, oh crap, I've eaten some chocolate, so I'll just keep eating and start again tomorrow, and sort of say something like, well, it's okay to sort of go off track and I'll just step back onto the plan and keep going from there. Now, psychologists, we really like maps and charts, so this is me making a map. I'll let you all let that sink in, but I think this can be a really nice way to help someone conceptualise that's leading to loss of control eating or disordered eating, or however the client wants to define it. You can work through this in a sequential way, but I think sitting down with the client and helping them identify these areas and deficits can be really helpful, and particularly planning an organisation can be done also with the help of one of our lovely dietetic colleagues, and regular and adequate eating can be really important to protect against loss of control eating or overeating. And then looking at also including sort of long-term sort of enjoyment, and social eating is really important to reduce deprivation as a trigger. And monitoring can help identify other triggers that can drive unhelpful eating patterns. And then, of course, coming into managing thoughts, beliefs, emotions, and coping skills is really helpful. And that can be addressed through a lot of different types of therapy. And in there, I haven't mentioned his body image because Gemma's addressed that really nicely. Finally, in terms of managing expectations, I think this is a huge thing that we need to help people with long term. And one of the things that people forget is how normal it is for your readiness to change and your ability to cope to change as life progresses. So sitting down with someone and helping them think about, how can they maintain progress long term in a really thoughtful manner, even writing it on, even just a one-pager that they keep and they give to their partner or someone that helps them, can be really important to help them stay on track long term. I wrote a blog post on destination addiction, which is this idea that once I get to a certain point in life, like lose a certain amount of weight, I'll be really happy and everything will be, unicorns and rainbows. And quite a lot of my clients felt personally attacked and understood by that, because people do get caught up in this sort of belief that once I make this change, everything will be sorted. And I think everybody knows that we might think it, but we sort of realise, hang on a minute, life continues. So it's really important to help people think big picture, think long term, think about what the triggers might be, that might undermine them, whether it's pregnancy in the future, someone, parents aging, whatever it might be. Think about how they could draw on their coping skills and where they would get more support if they need it. So that's the end of my talk. And I guess in terms of books, I really liked, I used the Waller book actually for eating disorder treatment, and also there's a book by Radcliffe, Living with Bariatric Surgery, that I think is really helpful. So if you want to, yes, yeah. So there's a new one.
Understanding and Managing Emotional Eating.
Yes,
Brand new.
yes.
Brand new.
Yes, sorry.
And it's a manual, it's a self-help manual.
It's so beautiful, thank you for writing it. So yeah, those resources are fantastic. So thank you so much for listening to this. And
Okay, well, where are my, there we are. So my disclosure is after those talks, I'm feeling rather intimidated. I hope that I can measure up. Also, because we have 20 extra seconds, I'm going to put in a plug. I am signed up to go on the Taste of Melbourne tour from 10:30 to 2:30 on Saturday, but apparently no one else is signed up. And if no one else signs up, then they were going to cancel it, or I have to pay double and go by myself with a guide who may or may not be a pleasant person to spend 4 hours with. So I put something on the social posting on the app, and also come see me if you would like to sign up for this for Saturday. I would love to spend time with one or more of you during that time. Okay, and someone else told me to say that, by the way. I wasn't going to, but anyway, okay, so having dispensed with that, I am going to be talking about something very, very different, which is substance use after metabolic and bariatric surgery. And I guess the first question is, why are we even talking about this? Why did IFSO ask me to literally come halfway around the world to talk to you about alcohol and other substances? And there's, of course, lots of reasons why we care about substance use, both before and after surgery, but today's session is focused on post-op, so let's look at that in the interest of time. We do know that after surgery, there is a documented risk of post-operative addiction issues, and if a patient is using or misusing substances after surgery, then we would worry about, of course, the impact that would have on their health and their safety, and even if their health and safety are not at risk, we would expect that substance use or abuse would likely have an impact at least on postoperative adherence and outcome. So let's dive into that in a little bit more detail. And to begin with, I'm just going to very briefly review what we know about postoperative substance abuse issues, starting with what we know about drug problems after surgery. And I will tell you there's very, very little research out there on the prevalence of those kinds of problems. But what research there is on this suggests that frank drug addiction problems after surgery are pretty rare, but as a caveat, I'm going to say that there is pretty robust evidence that among people who were not regular users of appropriately prescribed opioid pain medications before surgery, there is a subset of people that's not insignificant who develop new persistent use, not necessarily abuse, but people who become persistent users of opioid pain meds for the first time after surgery. I will also say this is not unique to metabolic and bariatric surgery. This is seen across all types of surgery, but we are interested in metabolic and bariatric surgery, and our patients are no exception to this. Now, what we know a lot more about is the prevalence of alcohol problems after surgery. And we do know that post-operative problems with alcohol are the most common type of post-operative addictive problems by far. This is definitely a thing. And we know that this can happen after both the bypass and the sleeve. We used to think that it might just be the bypass. We don't tend to see this after the band. Now, there's much more research about this in bypass patients, and in that population, we know that the majority of the postoperative alcohol problem cases, regardless of how you're defining alcohol problems, are actually in people who did not have those problems before surgery. And we also know that alcohol problems do not tend to start right away after surgery. With the bypass, which again we know more about, the risk period seems to begin about 1.5 to 2 years post-op. There's a little evidence that with the sleeve, that risk period starts a little bit earlier. And again, we don't have long-term data on this in the sleeve, but we do know that in people who've had the bypass, the risk of developing a problem with alcohol after surgery continues to go up over time, which is the opposite of most complications of surgery, right? Those we expect the risk to go down over time. Okay, so now we understand a little bit about addictions after bariatric surgery. What the heck are we gonna do about it? And I love the fact that this audience is mainly not behavioral health providers, because the behavioral health providers might have more of an idea, but this may actually be helpful information for you. So let's start looking at treatment. And unfortunately, no research has been done specifically on the treatment of patients who have had metabolic and bariatric surgery who have addictions. However, there's no particular reason to suspect that people who've had metabolic and bariatric surgery would not respond the same way to approaches that we already know work for treating addiction. So CBT, 12-step approaches, and even some pharmacological treatments as well. So you don't need to seek out specialty bariatric addiction services, which is good because they don't exist, but I would definitely advise any bariatric practice to work on creating a database of substance abuse treatment providers and facilities to whom you can refer patients who you find are experiencing these kinds of problems after surgery. Now, obviously, what we really want to do is to make sure that people don't even develop these problems with addictions after surgery. So it makes a lot of sense to really be focusing on prevention and early identification. And one of the reasons for this, of course, is that I'm not sure how it is here or in other countries, but in the United States, it's definitely true that we tend to see, especially those psychologists, tend to see the patients a lot more often before the surgery than we do afterward. So the first thing that we should really all be doing, all disciplines, is educating our patients about the risk of problems with substances after surgery. And to help you do this, a consortium that I'm part of actually developed an educational resource for patients on this topic, and this is available for free on the IFSO website. I've put the URL there, but if you just go to the IFSO website, I think it might be on the integrated health page. Or if you just search for that title, it will probably take you, on Google, it'll probably take you right to that. So we should be providing this education before patients have surgery, and then of course we do need to be refreshing that education after surgery as well, because of course none of the patients think that it's going to happen to them, so they may not be really watching out for this. And of course what goes hand in hand with education is that we need to be monitoring all of our patients after surgery for signs of increased or new onset substance problems. And it's especially important for us to remember that the high risk time for this seems to be at least a couple years, if not many years, after surgery. So we really need to do long-term monitoring. And obviously, our resources are limited, so we may want to be focusing particular attention on the people who may be more at risk, which I did not cover because this is a short speaking slot, but I will say there's a few factors that have been found to be associated with a high risk of alcohol problems after surgery, and these may be risk factors for other kinds of addiction problems as well. One of them is a younger age. We also know that heavy pre-op use of alcohol is a predictor of alcohol-related problems after surgery, and also family history, genetic history of addictions also seems to be a predictor. So I tell patients, if any of these applies to you, being male also, by the way, then really file this away. So, okay, I'm advocating for close monitoring of substance use after surgery. How do you go about doing this? As a psychologist, I'm very comfortable with asking people about substance use, but for those of you who are less accustomed to asking about this, I've prepared some sample questions that you may want to ask when you're assessing for this, starting with alcohol. And first off, you want to ask about frequency. How often are you using alcohol? And also how much, the volume. How much do you usually drink on a typical occasion when you are drinking? But when you hear that number, and especially you Australians, because you can really put it away, remember, as we all know now, that for both the sleeve and the bypass, alcohol is absorbed to a much greater extent and more rapidly. So you want to warn people about that. And if someone says, oh, I have 2 drinks every day, that may be quite a bit. We would look at that differently than if someone who hadn't had surgery is reporting that. You also want to find out if their current frequency and volume is an increase of use before surgery, but you also need to ask a few other questions about their use as well. You want to get a broader view of how the alcohol use is affecting the patient's well-being, which you can do by asking questions like, has anybody had any concerns about your alcohol use, including yourself? Has the alcohol use been causing any consequences in your life, in your work? Is it interfering with your relationships? Is it affecting your weight trajectory? And if you get any answers at all that concern you, you would want to at least refer for further assessment and possibly treatment. And asking about drugs can be done pretty similarly, but here you want to make sure that you ask specifically about using prescribed opioid painkillers. And even if the patient has a prescription and they're using them exactly as prescribed, you might want to ask if they are using them more than they did before surgery, because as I mentioned earlier, that there's this problem of new onset, persistent prescribed opioid pain reliever use after surgery. And if the patient has been using drugs, you do want to ask if this is an increase or even a new behavior since surgery, although of course, if the drug use, even if it's not new or it's not more than before, if they're having drug use, that's probably should be addressed. And then there's one more thing that you should probably be asking post-op patients about as well, and Vash mentioned this. I was really glad to hear her mention this. Are you engaging in any behaviors that you're doing too much of since surgery? Gambling, spending money, sex, or shoplifting. There are some anecdotal reports of patients engaging in these kinds of behaviors compulsively after surgery. It's even in the research, it's quite rare to see this. In my own practice, it's quite rare to see this, but I've seen like a couple of shoplifting issues, a lot more of the gambling and the spending, sometimes the sexual issues. And again, is this a new behavior since your surgery? Now, obviously, if a behavior is problematic, it's problematic, but it's especially notable if this is something that happened that is new since surgery. So this all assumes that you actually have the opportunity to see the patient and monitor them for these problems after surgery. But I need to go back to the point that I made earlier, that the risk for postoperative addictions seems to increase over many, many years. And usually we are only seeing our patients consistently in the first year or so. So these problems are developing long after these patients have stopped coming to see our clinics. So I think the one thing that we really need to be doing is educating all providers who are likely to be seeing our patients years after their surgeries, primary care physicians, endocrinologists, certainly behavioral health providers, and other specialties as well. And I think this is probably the most effective means of prevention and early identification that we have. And it's also where we have the most room for improvement as a field. So let's get out there and educate our non-bariatric colleagues and ask them to keep an eye on our patients after they have left the nest. And here's a list of my references. These handouts have also been uploaded. Thank you. I'm back. So next we have Lorena Brown. Dr. Brown is also a clinical psychologist and an ANZ AED credentialed eating disorder clinician. She's passionate about helping people to change their relationship to food, eating, and body image. And she has the privilege of supporting people around Australia on their bariatric surgery journeys. I'm going to have trouble pronouncing this, through the Noe Clinic? Noe Clinic on Sydney's North Shore, and through her own practice based in the New South Wales Central Coast.
Thanks, Stephanie, and particularly for the smooth transition from presenter to introducer. I should just say, by the way, I'm not a doctor, but maybe one day. It's my pleasure to be the lucky last speaker at this workshop this afternoon, and I'm going to be presenting specifically on the relationship between attention deficit hyperactivity disorder, or ADHD, and obesity and metabolic surgery. And I have nothing to declare. So when I found out that I was going to be doing this talk, I went to some of my clients who are living in larger bodies, who have a confirmed diagnosis of ADHD, and asked whether they'd be willing to share with you what it's like for them to be living with ADHD. And this is what some of them said. So I'm not going to go through all of this for the sake of brevity, but just to pick out a few of those things. My brain is like a bucket of frogs jumping all over the place. Some days, my brain feels like I've stuck my fingers in a power socket that I can't disconnect. It feels like there's a panel discussion in my brain, but no one ever finishes their train of thought until maybe 3 a.m. I started a work project yesterday morning. Then I looked at the time and suddenly realised it was 5 o'clock and I hadn't had any lunch. I have no idea where that time went. So much for regular eating. So, to give it more of a clinical definition, ADHD is a neurodevelopmental disorder with an onset before the age of 12, in which we see differences in the executive functioning system, including in working memory, planning, sustained attention, inhibitory control, and emotion regulation. And there are 3 types of ADHD presentation or diagnosis. Firstly, we have the predominantly inattentive type. So that's difficulty focusing and sustaining attention, but people with this type of ADHD will tend to hyper-focus on things that interest them. It's being disorganized, daydreaming, time blindness. Then we have the hyperactive impulsive type, and that's more the stereotypical image that we have of ADHD, in which we see excessive energy and interrupting other people. And then we have the combined type. And I'm going to suggest that we already know who these patients are. They are your patients who show up late, who forget their appointments, who come on the wrong day, who double book, who don't do their food diaries. And if you're lucky enough to not do your own booking, so you might not be aware of any of this, just ask your front desk staff, because they can be such a rich source of information. And crucially, there are differences between the male and female presentations of ADHD. So males are more likely to present with the hyperactive or, the more stereotypical type. Females are more likely to have the inattentive type. And females are really good at masking their symptoms. So historically, they've tended to slip through the net of assessment and diagnosis. And that's one of the reasons why we're seeing more and more women, particularly in middle age, being diagnosed. And why is this important? Well, who are the majority of our clients? They're women. So let's look at some of the stats on ADHD and obesity and related health problems. We know that people with ADHD are between 1.5 to 4 times more likely to be living with obesity. We know that they're 3 times more likely to have type 2 diabetes. And we know that childhood ADHD predicts a higher BMI in adulthood. There's a growing body of research around the relationship between ADHD and binge eating and binge eating disorder. Now, of course, not everybody living with obesity has binge eating disorder, but of course, there's some overlap. So ADHD is associated with the addictive-like disordered eating, particularly loss of control eating that Carmel was talking about earlier. So they might not necessarily be those patients in a restrict binge cycle, but those patients that tell us that they just cannot stop eating however hard that they try. And the higher the BMI, the bigger the relationship is between ADHD and binge eating. And in fact, between 20 and 30% of people with BED also have ADHD. However, it's important to note that the relationship between weight and ADHD exists independently of binge eating disorder in people of a higher weight. So let's look at some of the mechanisms underlying this association. Firstly, we have inhibitory control and impulsivity. In that people with ADHD have greater difficulty making food choices that focus on future consequences rather than immediate rewards. Secondly, inattention and interoceptive awareness. In that people with ADHD have poorer awareness of internal cues, including hunger and satiety cues, which might mean that they forget to eat. And this is particularly the case when someone's hyper-focusing, just like in one of the quotes from my guy earlier on, whereby they suddenly become really hungry and then they are more likely to just reach for whatever food's available, which might not be particularly nutritious, and they may overeat. Furthermore, it's been proposed that higher levels of distraction while eating might mean that people with ADHD are less aware of how much they've eaten, and therefore they're at risk of overeating. Thirdly, differences in executive functioning might mean that it's harder for people with ADHD to do things like planning their meals, setting and working towards goals, putting an exercise routine into place, and even attending appointments with us, with health professionals. Fourthly, difficulty with emotion regulation is a symptom of ADHD, and what's one of the things that people might do to try and regulate their emotions? It's eating. And finally, we've got the dopamine hypothesis, in that we know that people with ADHD have lower dopamine levels than people that don't have ADHD. We know also that certain discretionary foods increase dopamine levels. And so this suggests that people with ADHD are predisposed to eating these type of foods to get a dopamine hit. Moving on specifically to ADHD and bariatric surgery, some researchers suggested that between 27% and 42% of people seeking surgery have ADHD, and a large meta-analysis published this year found that ADHD symptoms are 3 times as common in people seeking surgery than in the general population. But when we look at outcomes, comparing people with and without ADHD, the data's a little bit limited so far. And we're also not sure from that data which participants are being treated for their ADHD with medication and which aren't, so that's a little bit of a limitation. So we're a little bit unsure on what outcomes post-surgery are like for people with untreated ADHD and what happens beyond the 2-year period of follow-up that's been involved in those studies. So in summary, why is all of this important? Well, ADHD could be a really crucial part and a missing piece of the puzzle in the patient's picture. If the patient meets criteria for binge eating disorder, for example, is it actually ADHD that's the primary presenting concern and therefore in need of treatment? And regardless of whether or not the patient meets criteria for binge eating disorder, how might ADHD, whether it's treated or untreated, affect their treatment plan and their metabolic surgery journey? As Simon was saying in his talk a couple of days ago, we're asking so much of our patients. We're asking them to take the vitamins, monitor their food intake, turn up to appointments, plan their meals. That's hard enough for any of our patients. But just try to imagine what that's like if your head feels like a bucket of frogs. So screening is really important. And I think now that most psychologists working in this field are routinely screening for ADHD, just as a matter of best practice. If you don't have access to a psychologist, well, firstly, you know where we are and who we are. But if you still can't get access to a psychologist, there are some screening tools that are validated and ready available on the internet, such as this one, the ASRS, easily scored and can be used by anybody. That's all from me for this afternoon. Thank you for your company today.